I guess we should get going. It's a couple of minutes past 5. So hopefully everyone online can hear us well. If not, put something in the chat and Ellis next door can run in and help sort us out. But we've got a good attendance here in the room, which is nice to see. And hopefully, I can't see the attendees online. That's certainly worth you joining online earlier on today. So delighted to welcome back Ramona to the department today. So Ramona joined us around 2017, 2018, so around 5 years ago, having trained in Vienna as a radiologist, PhD in neuroimaging. I didn't know that it was in neuroimaging, but then moved a little bit more inferior in the body to do a lot of breast imaging with us and research, which we talk about today, particularly related to hyperpolarized carbon imaging, and really led on that and pushed forward some of our first publications in that field with Ferdia. Some great work, which I'm sure we'll hear about, and also has done some radiomic work with ovarian cancer, and unfortunately has left us, gone back to Vienna to work in medical imaging in AI, leading a group there, but has maintained a research contract with us, so hopefully we can still collaborate on projects moving forward. So I'll hand over to Ramona now.
Thank you very much. Yes, indeed, I changed from neuroimaging to breast imaging, and a psychiatrist once commented this with you focus on the lipid-rich organs, and I think that's probably a very nice description. So today I would like to give you an overview of the work that we did in hyperpolarized C13-MRI in breast cancer over the past few years. Let's see if I can, yes. Most of you know that one of the hallmarks of cancer are alterations in cell metabolism. And lots of cancer cells show increased rates of glycolysis and consequently also increased sugar or glucose uptake. And that happens on the one hand under hypoxic conditions, but also when there is ample oxygen supply. It happens under what is summarized as the Warburg effect. So in many cancer cells, we observe increased glucose uptake, and then increased conversion of pyruvate, which is a breakdown product of glucose, into lactate. And we, with our hyperpolarized carbon-13 MRI, we are working on visualizing and imaging and quantifying that conversion of pyruvate to lactate. And our competitor, our competing imaging modality is FDG PET. And just as a quick reminder, I don't know if you can see it very well on this slide or on the projection of the slide, FDG PET basically images the intracellular uptake of F18, of the F18 labeled glucose analogon, and the trapping of that inside the cell by hexokinase. The FDG gets phosphorylated and is basically trapped within the cell. But what is nice about hyperpolarized carbon-13 MRI is that we inject pyruvate, the breakdown product of glucose. It's labeled with carbon-13, and we basically image steps further down through glycolysis and cell metabolism. There are, especially in breast imaging, there are limitations to imaging or quantifying lactate within tumors, and the main problem is that, as I said, the breast is a lipid-rich organ. There are lots of lipids surrounding breast cancer, and we know that there are also lots of lipids within breast cancer. And on proton MR spectroscopy, it is almost impossible to separate lipid peaks from lactate peaks. So hyperpolarized carbon-13 MRI is a very unique method in that it allows us to image lactate formation within breast cancer. And so there is a number of MR active but not radioactive nuclei, and carbon-13 is one of them. The pyruvate, that glucose breakdown product that we use, is labeled with carbon-13. We inject it intravenously after this process of hyperpolarization, which I'm going to explain in a second. That pyruvate is then taken up intracellularly via transmembrane transporters, monocarboxylate transporters, MCTs, and it enters the cell, and then it basically undergoes the same enzymatic conversion that endogenous pyruvate undergoes. And in breast cancer, what we see on hyperpolarized carbon-13 MRI is that the majority is converted to lactate. And that reaction is catalyzed by the enzyme lactate dehydrogenase. So that's basically what we image. As I said, carbon-13 is an MR active nucleus, but just labeling the pyruvate and injecting it intravenously wouldn't allow us to acquire images within any reasonable amounts of time. And that's why we need this process of hyperpolarization. What is hyperpolarization? Whenever we place these MR active nuclei within a strong magnetic field, like an MR scanner, approximately half of those spins align with the magnetic field, and approximately the other half opposes that magnetic field, and they cancel each other out. There's only a tiny imbalance, and this imbalance is what gives rise to our MR signal. And during the process of hyperpolarization, we basically increase this imbalance to increase our signal, or the signal to noise ratio in our images. And you're all very, very familiar with the hyperpolarizer or the hyperpolarizers here. And this whole process of hyperpolarization takes several hours. The pyruvate solution is placed in a strong magnetic field, is cooled down to almost absolute zero, and there's a EPA is added to that solution as an electron paramagnetic component. And by microwave irradiation over several hours, this whole solution is hyperpolarized, and the hyperpolarization is transferred from the electrons over to the carbon-13. The sample is, or the solution is frozen clearly in this very cold environment, and ultra-heated water is then used to dissolve it. It needs to undergo several steps of quality checks before it can be injected intravenously. And then we have a few minutes to acquire our images. And as you know, we use a clinical 3 Tesla scanner. We have a dedicated C13 tuned breast coil. And we can acquire images at the temporal resolution of about 4 seconds. In comparison to other areas that I worked on, this technique is technically relatively complex. That's also why it's often prone to errors and failures. So it's not 100% straightforward, but once you get images, it is a very satisfying work, I would say. Yeah, because you can learn a lot about tumors, and I'm going to show you some of the results, especially in the response assessment, that I think are still worth doing this. And of course, with technical complexity also comes a relatively high level of costs per exam, and that's probably so the 2 areas that I have been working on are radiomics and hyperpolarized carbon-13 MRI, and I think that those are the 2 extreme ends of the spectrum of technical complexity and costs. But it's a nice balance, I think. Yeah, this is a nice example of our C13 images of a patient with a triple negative breast cancer. On the top image, you can see the pyruvate being delivered to the tumor, being taken up, and slightly later you can see how the C13 label is exchanged between the pyruvate and the lactate that is formed within the tumor. And what we do in breast, we mainly focus on the lactate to pyruvate ratio. So we sum the signal for both metabolites over time, and we calculate the lactate to pyruvate ratio. as a measure of metabolic activity in breast cancer. This is all relatively complex, as I said, it's costly. So why are we doing all this? The reason for that is that there is a large number of preclinical studies on different types of cancer models. And breast cancer is one of the diseases or models that have been investigated quite extensively using this technique. And from the preclinical world, this imaging technique has always been promoted as one that could potentially assess response to anti-cancer treatment at a very, very early stage after the first dose of treatment is given. And this is just one example of such a study. It's one of those relatively rare examples where C13-MRI is compared to FDG PET. It's a direct comparison. And these are, this is a mouse or rat model of triple negative breast cancer. The treatment that is given is not really representative of what we give in a clinical setting, but it's a so-called a trail agonist, and it induces apoptosis in these cells. But what was shown here very nicely is that within 24 hours of one dose of that treatment being given, a clear decrease in the lactate to pyruvate ratio was observed on C13-MRI, whereas on FDG PET, no clear changes have been seen, and that is a very strong indication that also in the clinical setting in breast cancer, we may be able to see response to treatment very early on. And another aspect of carbon-13 MRI using pyruvate is that in different disease models, it has been shown that the lactate to pyruvate ratio increases with disease aggressiveness. So the higher the tumor grade, the higher the aggressiveness of a malignant lesion, in this case pancreatic neoplasia, models of pancreatic cancer in animals. The lactate formation and also the alanine formation changed depending on the tumor grade. So measuring tumor aggressiveness and assessing response to treatment are the main goals that we followed using, and we are following using this technique. Now the question is, where did we get to in the translation into clinical oncological imaging? And I think breast cancer is a disease where it's worth investigating the utility of C13-MRI for the early response assessment. It's a very common disease. 1 out of 8 women will be diagnosed with breast cancer throughout their lives. And neoadjuvant chemotherapy, so chemotherapy before surgery, is becoming more and more common, especially in the more aggressive subtypes of breast cancer, like HER2 positive and triple negative breast cancers. Some of the advantages are that the chemotherapy before surgery can lead to better cosmetic outcome. It can lead to higher rates of breast conservation, so no mastectomy is needed. And one, or probably the biggest advantage, in my opinion, is that we can assess response directly. So the tumor is still there, we give treatment, and we can see whether the tumor responds or not. And especially in the triple negative and in the HER2 positive breast cancers, complete pathologic response, which is defined as the absence of any invasive disease in the breast or in any lymph nodes, is a very important prognostic biomarker. So a patient who reaches that after 5-6 cycles of neoadjuvant chemotherapy or targeted therapy has a better prognosis than a patient who does not reach this. However, we know from our patients, from oncologists that we work with, that these patients, so that this whole duration of 5 or 6 cycles of chemotherapy, it's very, very long, it's several months. And our patients, they suffer from the side effects of the treatment. They know they live with cancer. Some patients can even feel the lump in their breast. and it's so they need to live through this, not knowing whether the treatment works or not. And if they can get an early indication of whether the treatment is shrinking the tumor or is killing tumor cells, that can be extremely motivating for patients on the one hand, and on the other hand, if we knew that a treatment was not working or not efficacious in a patient, we could potentially, there are two options. One is patients could get a different type of treatment. They could be recruited into trials of novel targeted agents, or surgery could be brought forward, because if the tumor doesn't respond to neoadjuvant chemotherapy, those patients live with the tumor. We don't know very much about this, but there might be seeding of tumor cells. The tumor could potentially metastasize, and any earlier readout of response to treatment could be very, very beneficial. And we unfortunately, proton MRI, even with diffusion weighted imaging and dynamic contrast enhancement, is limited in its very early prediction of response to neoadjuvant chemotherapy. So I think this is a real clinical need. And of course, before you can assess response to treatment, you need to know whether you can actually successfully image breast cancers at baseline before they undergo any treatment. So that's what we did initially. We recruited patients with different subtypes of breast cancers, different grades of breast cancers. And from the preclinical studies, we knew that in the vast majority of cases, response would be identified as a decrease in lactate formation, a decrease in the lactate to pyruvate ratio. So what was important to us was that in those more aggressive breast cancers who we would want to image during neoadjuvant chemotherapy, we would need to be able to see lactate at baseline to then be able to see a decrease in lactate formation or the lactate to pyruvate ratio. And in this very, very first cohort, we found that in the more aggressive cancers, triple negative breast cancers of grade 3, or also hormone receptor positive breast cancer of grade 3, in those more aggressive breast cancers, we could see lactate and calculate the lactate to pyruvate ratio. And that was the groundwork or the basis for then going on to image patients before and after they started treatment. And we also looked at the expression of the transmembrane transporter that I mentioned earlier that mediates the intracellular uptake of pyruvate, and LDHA, which is a subunit of the enzyme that catalyzes the conversion of pyruvate to lactate. And we could show that the lactate to pyruvate ratio was positively correlated with the expression of the transporter and also of the enzyme. Metabric is a large cohort of patients with breast cancer whose DNA and RNA sequencing results are basically publicly available, and it covers or comprises over 2,000 samples. And the expression of LDHA, the subunit of the enzyme, and MCT1, the transmembrane transporter, we could see that they are significantly correlated with CA9 and HIF1 as hypoxia markers. And biologically, that makes sense because on the first slide, I showed you that hypoxia is one of the drivers of increased glucose uptake, increased glycolysis. And we could also show that overexpression of LDHA and CA9 as the hypoxia marker are associated with poorer overall survival and recurrence-free survival. And that means that those imaging results, the lactate to pyruvate ratio, which is also correlated with LDHA expression, may also contain some prognostic information, which is interesting in itself. But of course, we were most interested in seeing whether we could replicate those very promising results from preclinical study in the context of very early response assessment. And the very first case that we did, where we did early response assessment after one cycle, a full cycle of neoadjuvant chemotherapy, so after 3 weeks of treatment, was a woman with a triple negative breast cancer. And what we found here after those 3 weeks, the lactate to pyruvate ratio had decreased by about 1/3. And interestingly, we also did DCE-MRI at high spatial and temporal resolution. We performed pharmacokinetic modeling, and interestingly, K-trans had increased quite significantly. And so the results on C13-MRI pointed in the direction of good response, whereas the DCE-MRI results pointed in the opposite direction, that the patient may not have responded overly well. But at the end of chemotherapy, so after 6 cycles in this case, the patient underwent surgery. And on the surgical sample, the pathologist then defines whether the patient has complete response or not. And this lady had reached complete response. So at the very early stage, after 1 cycle, the results from the hyperpolarized C13-MRI pointed in the right direction. But it was after a complete cycle of neoadjuvant chemotherapy, and a lot of the preclinical results were obtained, as I showed you, after 24 hours. So we wanted to try and see if we could go to an earlier time point during treatment and show response as well. The next cohort of patients comprised 7 patients initially, triple negative breast cancers and HER2 positive breast cancers. And again, we imaged them before they started treatment. And the second time point was around 1 week, between 7 and 11 days of treatment. And again, we calculated lactate to pyruvate ratios and looked at the changes between these 2 time points. And so the good news is that we could distinguish between patients who reached complete response and who did not reach complete response. And here on this figure, I don't know if you can see can you see the mouse? Yes. The pink bars here are the patients who reached complete response. And if we take, if we use a threshold of an increase in the lactate to pyruvate ratio of 20% or more, we find all those patients with complete response on the left side and almost all patients with non-complete response on the right side. So this is a good result. And in comparison to diffusion-weighted MRI, DCE-MRI with pharmacokinetic modeling, this was the best result. The C13 was the only imaging technique that could distinguish that well between responders and non-responders. We had 2 patients in this cohort who did not only receive the standard of care treatment, but who received an additional treatment with a so-called PARP inhibitor. And those are the gray and the pink, or they're represented by the gray and the pink bar with those stripes. And interestingly, the one patient who did not reach complete response and who still had this increase in the lactate to pyruvate ratio was one with who received the PARP inhibitor. And I'm going to explain why we think this was the case. I actually wanted to show another slide. So the image is not contained here. After those 7 patients, we continued the study. We're now at 11 patients, and still the threshold of 20% increase in lactate to pyruvate ratio separates the responders from the non-responders, which is good. And the thing about the PARP inhibitor is PARP inhibitors are specifically given in patients with triple negative breast cancer or with a BRCA mutation. And what PARPs do when they're not inhibited is they mediate DNA repair when there is a single strand DNA break. PARPs assemble around that break, and they help repair that single strand DNA break. And if that doesn't work, a double strand break results, and that leads to cell death. So PARP inhibitors basically increase single strand breaks to double strand breaks, and that leads to cell death. And that happens a lot in cells that are that carry a BRCA mutation, and even more so if the chemotherapy contains platinum. Platinum-based agents increase single strand breaks, and that leads to even more cell death. And it has also been shown that these PARPs, they use up a lot, up to 90% of the NAD within cells. And if you throw a PARP inhibitor on top of this, the PARP inhibitor competes with the NAD for binding of PARP. So if the PARP inhibitor is added to this system, suddenly a lot of the NAD is set free and is available for the conversion of pyruvate to lactate. And that is probably one of the reasons why we see an increase in the lactate to pyruvate ratio in all patients who receive PARP inhibitors. And that means that we probably need to apply a different threshold for those patients. So we just need to be very careful about the treatment that our patients get, and we need to take that into account when we look at our results and set any thresholds. Generally, as I mentioned earlier, from the preclinical studies, what was reported then was that as an important sign of response is a decrease in the lactate to pyruvate ratio, whereas we found an increase in those patients who responded well to treatment. However, there are a few studies where researchers observed something similar compared to what we found, and in very meticulous analysis of the different contributing factors, it turned out that changes in the expression of MCT1, the transmembrane transporter, could potentially be responsible for this increase in the lactate to pyruvate ratio. And that is a bit of a, maybe not a novelty, but I think the focus of a lot of the preclinical work has always been on LDHA, and MCT1, I think, was a little bit disregarded, but I think it's something to keep in mind and to include in this equation, especially if the results point or show the changes that we observed with this increase in the lactate to pyruvate ratio. So MCT1 expression or MCT1 location in the cell membrane is probably a factor that contributes to this increase in the lactate to pyruvate ratio. As I said earlier, we could also show that the lactate to pyruvate ratio is significantly correlated with MCT1 expression, which could support this idea. The possible other explanations are that the particular chemotherapy agents that these patients get, like taxanes, they have a very well-known anti-angiogenic effect, and that can lead to hypoxia and could also increase lactate formation within these cells. That has been shown in very few studies, so it could also contribute to this. And of course, human experiments are very different from experiments in mouse or rat models, because the immune system is completely different, and immune cells infiltrating tumors as a sign of response could potentially also contribute to this lactate to pyruvate ratio increase. And the time point at which we image may also affect what we see. And very early on during response to treatment, very early after the first dose of treatment, these the redox status within those cells might be different from later stages. Like, and when I say later stages, this may be hours or days possibly, so that can also play a role. And yeah, that's already the end of the presentation. The summary, I think, is that there's a lot that we need to take into account, a lot to be considered. Ideally, we would have hundreds of fluid paths, and we would have patients who are happy to come back again and again, so that we can test different time points for response assessment. We can do lots of repeatability studies, but we are a little bit limited in the number of fluid paths that we have. So we probably need to be very smart about choosing the right time points and drawing the right conclusions from that. And with that, I would like to thank everybody who spent a lot of time and energy on these projects. Yeah, I'm happy to take any questions if you have any.